It's a great pleasure to be here, and this actually follows on quite nicely from one repurposed anti-epileptic drug to another repurposed anti-epileptic drug. And I'm going to talk about the Treat Wolfram clinical trial, which I've been involved in. I'm going to introduce you, first of all, though, to two patients that I first met many years ago now, when I was a trainee children's doctor at Birmingham Children's Hospital, who both presented what looked like common childhood type 1 diabetes, because that's all that was known really in the 1980s, and were treated with insulin just like everybody else was. But they did something very strange. Within 5 years, they described everything as like a curtain going down in front of their eyes. They lost their colour vision, and then within 10 years, they lost their vision. And the top right-hand picture is the two beautiful children when they were diagnosed with diabetes. And the bottom left picture is those on holiday in Cornwall when they were about age 15 and 13. And you can see from the white sticks that they now have severe visual impairment, unable to see the beautiful horizon around them. But it does end with a somewhat happier story. The bottom left picture is the sister in here who qualified with a first degree in mathematics from Sheffield University in her 20s. And she's still with us and is an absolute hero. The condition continues. It's basically a neurodegenerative form of diabetes. It used to be known by an old acronym, which we don't tend to use anymore, but it mentions that these patients tend to develop neuropathic bladders, diabetes and brain atrophy, a neurodegenerative disorder for which, like 80% of rare diseases, there's no cure, no specific treatment, just supportive support. And it's an endoplasmic reticulum stress disorder involving the unfolded protein response pathway. And the picture of the natural history on the right is what I did for my PhD about 30 years ago when I was still in short trousers, you can see on there. This is the timeline of the research that's happened. It was first described by Dr. Wolfram in the Mayo Clinic in 1938. In 1995, we described the natural history and inheritance from a study based in Birmingham. The gene was identified by colleagues in Washington University, St. Louis, in 1998. And then we were able to set up a National Health Service England highly specialised service for patients, which allowed us to bring patients together for research. Found a drug target, a drug scheme, and then you can see to 2017, we finally got to funding for a pivotal clinical trial. So just walking through those aspects of this, the drug target aspect was found by an observation from one of our PhD students that one of the key cell cycle regulators, P21-CYP, that can hold cells in a stable formulation, was reduced in cell models on the right-hand side of Wolfram syndrome. So these are cell models KD1, KD2, KD3 with P21-CYP levels reduced compared to controls. But what was really interesting is that in those cells that retained some P21-CYP expression, they had a better survival. They didn't tend to die off so early as the others did, which led to the hypothesis, can we increase the expression of P21-CYP with known repurposed drugs, hold the cells in G1 phase, and hopefully give them time to recover? So this led, first of all, to putting a patent out before we did anything else, which was thankfully the support of Zhu Zhenaji, followed by high-content cytometry and a very small scale by today's standards compound screen, choosing already licensed drugs that were known to increase P21-CYP expression, that were licensed for use in children, and that were known to cross the blood-brain barrier, as we obviously wanted to address the neurodegeneration. 5 of these out of the 21 tested showed some effect, and the one we chose was sodium valproate, another anti-epileptic drug. Given that we've got 50 or 60 years of use in thousands and thousands of adults and children, we know the toxicity profile of this. We know it's a neuroprotective agent via a number of mechanisms, including HDAC, of course, as well. We had some safety data in 3 patients that had been treated with Wolfram syndrome who'd had sodium valproate. And it was off patent, so therefore we had the freedom to operate from the IP point of view. So having secured a patent on it, we applied to EMA for orphan drug designation and the FDA for that, which is really helpful. And I think that's been covered already and discussed, I think, in this conference in the last couple of days. And what was really useful to us was we went to the EMA Committee on Medicines for Human Use, so EMA protocol assistance. They were able to give us scientific advice on the design of a clinical trial and protocol assistance to actually develop this forward. And we did that before we actually had funding to do the trial. Based with that support, we then applied to Horizon 2020. We got to stage 2, but sadly we were unsuccessful after that. And I was really pleased to find that the United Kingdom Medical Research Council, through their Pathway funding scheme, we applied to them to actually do an efficacy study of Wolfram in a mouse model. There'd already been some data on sodium valproate in mice, but we wanted to extend it. And then we proposed for a phase 1 trial. But they awarded us, to our great surprise and delight, to move directly to a pivotal clinical trial because sodium valproate was a drug for which there's a lot of data out there already. And they also, which I think was fantastic, gave us funding to support recruitment throughout the European Union, given that it's an ultra-rare disease, and we were unable to recruit sufficient patients just in the UK. So the EMA protocol assistance helped us with the design. Now, going back to 2015, and I don't think this would apply today, they insisted on a gold standard, randomized, double-blind, placebo-controlled efficacy and safety study, despite the fact that this affects 1 in about 750,000 patients. So that was a task. The justification was that if we removed as much bias as far as possible by randomization and blinding, and that we could use a placebo because there is no approved treatment for Wolfram, that they would then they would then have some flexibility around the p-value, provided we were able to demonstrate that the study had a power of 80%. So they set us some quite stringent targets, and I think this reflects 8 years ago, and I don't think that the advice would be the same today. However, we were stuck with that. Now, I'm a children's diabetes doctor, endocrine doctor, and I was very happy to have diabetes as a primary outcome and see if we could improve it. And I was also very keen to have a look at MRI imaging of brainstem volumes, which we know get reduced due to brainstem atrophy as part of the neurodegeneration. And the EMA Protocol Assistance Committee quite rightly said, patients don't care what their brainstem volumes are. They're not interested in that. You've got to have a patient-relevant outcome for this. So we ended up choosing vision. And the reason for this is the lady I referred to yesterday, the wonderful leader of the French Wolfram Association, Nolwenn Lafloche, who literally locked us in a hotel for a weekend and would not let us out until a group of international researchers had agreed to work together for this clinical trial, which we've done. And they also, with their support, we asked them what did they think was most important to them. I assumed that this was going to be diabetes, because that's what I was interested in. And they said they don't care about diabetes. You can give insulin for diabetes. Nobody worries about that. What they were worried about was their children losing their sight by the time that they were adults. And each of these patient support groups in the UK, France, USA, and Spain all ranked loss of vision as #1. So I had to repurpose myself into an ophthalmologist and think about how to choose vision as the primary outcome of this. We were able to do this with great support from a research clinic in St. Louis from Professor Tamara Hershey, who'd actually tracked the progression of vision loss in some young adults with Wolfram syndrome over a period of years. And the graph that I'm showing you shows visual acuity on the y-axis. Well, at the bottom, visual acuity of 0 is 20/20 vision, perfect vision, and a visual acuity of 2 would be counting fingers only. And on the x-axis is the age of patients in years, and each of those coloured lines behind there is an individual patient whose vision is tracking from the bottom left corner of the graph to the top right, i.e. the vision is getting worse over time. Drawing a regression line through that, we could estimate a progression over time, which is the central red line. And we powered the study to try and make a clinically meaningful reduction in that progression by at least 60%. And what that would mean for a child is that they would have retained useful vision well into their 20s, if we could achieve this, to get them through their secondary school and their college education and equip them much better for a future life with this. And the hope that this would give us time while we're waiting for gene therapies or other more advanced therapies to come through. So then they advised us on the sample size for this. We, at that stage, proposed a Bayesian approach. In 2015, the EMA wanted frequentist approach and hypothesis testing. They did accept a 2-to-1 randomization in favour of the active drug, which was very helpful. But if we looked at a single point difference in vision at time point 1 to time point 36 months, 3 years, we'd need 600 patients, and we didn't know 600 patients. If we looked at it as a continuous variable, we could get that number down. One eye with repeated measures every 6 months over 3 years got the number down to 70. And then by some additional statistics, actually looking at 2 eyes, despite that there's some correlation, we could get the number down to 64. And that was manageable across Europe. They then advised us on the choice of dose for valproate. We looked at the dose in the formularies, and the committee advised us that we should choose the highest tolerated dose in order to achieve an effect size that we did. But we obviously had to follow the National Pregnancy Prevention Guidelines because of the concerns about harm to the unborn baby. So the trial schema shows 2-to-1 randomization in favour of sodium valproate, 11 visits over a 3-year period, and it's a very long trial because it's a neurodegenerative disorder, and we're trying to check differences between vision. We screened 89 participants across Poland, Spain, France, and the UK. 7 to 7 consented and 6 to 3 were recruited. Our colleagues in Europe, in the European Union, were fantastic and have been absolutely brilliant in helping support our recruitment. And our patient support group, Wolfram Syndrome UK, funded the travel and the accommodation. Here you can see the recruitment, and you can see great early recruitment in 2019, and then a flat period. You can guess what that is. That was COVID. And this really paused us at that stage. We really struggled just to keep the patients in the trial, and then we were able to take off again when we got to the end of COVID. So that sort of stopped us. Where are we now? Patients are visiting every 6 months for eye checks and every 12 months for a brain MRI, and we're doing various other safety blood tests. The outcome, if the last visit is in October, if the trial, we've recruited sufficient participants to have a 80% power. The trial hasn't been stopped midway through. We're obviously hoping that there will be a statistically significant difference in outcomes on allocation at the end. If the trial is a success, then we'll be doing a report to the funder, the UK Medical Research Council, in 2025. And I'm really grateful that the Early Access to Medicine schemes in the UK has been in contact, and that if this trial shows efficacy, they'll kindly support us to actually get the treatment to the patients. We will need to go through the EMA for marketing authorization, and we'll need to work with the regulators and probably find an SME that will be able to support us to put together a package of data. And I think I'd need to come to Remedial for that. The key challenge is, the main side of this, delivering a pivotal clinical trial in an ultra-rare disease. I think today's study designs wouldn't necessarily require a randomized controlled trial like this. Regulatory issues. Doing it as an academic study left 19 separate contracts for study setup for the different aspects, which changed every time we had a substantial amendment to the protocol, which has been 11 of them so far. Patients who would love to have taken part were ineligible because of the trial delays, and this was mentioned by a speaker yesterday. It was a disaster for us. The drug company would not provide sodium valproate. It's not worth their while, so we had to identify an alternative supply, and then we had to do stability testing of that drug, and that added 14 months to the trial. I have to say, and I can speak in my own personal capacity, our government, it was a complete disaster to go down the Brexit route. And it's really complicated issues by having to have a legal representative in the EU and centralised EU drug QC, etc. Possible solutions are, I think, what are being led by the UK Medical Research Council, and these are challenge nodes to improve on trial designs so that we can maximise external information, use historical controls, and have smaller sample sizes. So in summary, this is the first international pivotal trial for Wolfram syndrome, containing all the data elements in one trial that hopefully we'll need for marketing authorization. The first trial with patient-relevant primary outcome chosen by the participants, the vision, effectively. If we show efficacy, we're going to need some support to get through EMA marketing authorization. But we've now built a clinical trial network across the EU for future trials for this condition, and we've got legacies of longitudinal data, imaging, and quality of life, etc. So it's really important to thank the funders, the UK Medical Research Council, the patient support groups who have been absolutely invaluable across the European Union and, of course, Wolfram Syndrome UK. And, of course, this is a massive team of people that's put this together to deliver an academic investigator-led trial. Thank you very much.